Hey, what's going on, everybody? We're going to be going over second-generation antipsychotics for the mental health assignment. These are our group members right here, and myself and Brianna Cousin will be doing the presentation. So first of all, just an overview of what we're looking at. The second-generation antipsychotics, they're used to treat schizophrenia and bipolar disorder, and we do that by targeting dopamine and serotonin receptors in the brain. They have fewer movement-related side effects than the first-generation antipsychotics, but they pose more metabolic risks like weight gain and diabetes. Um, Clozapine is effective for resistant cases, but it requires strict monitoring, and the choice of antipsychotic depends on individual patient needs. So we choose these over the other ones because they have less of those EPS side effects. Uh, as far as the pharmacokinetics go, the absorption for these varies depending on the route. So oral drugs are absorbed in 1 to 6 hours, but they also have new disintegrating tablets that can be absorbed within 2 minutes. They're metabolized in the liver by the cytochrome P450 enzyme, and the half-life ranges from 10 to 30 hours, with the exception of patients with impaired hepatic functions. If your liver is not working, it's going to affect how these drugs are metabolized in your system. Pharmacologic effects. Second generation antipsychotics have two main differences in the mechanism of actions. The first one is they block 5-HT receptors in the brain, and they are faster on and off the D2 receptors. So that means they attach and detach faster than the first generation ones did. SGAs are more effective in treating negative symptoms, and they reduce the risk for those EPS and tardive dyskinesia side effects that we see with a lot of antipsychotic drugs. Continuing on the pharmacologic effects, those 5-HT receptors in the brain, they inhibit the release of dopamine, which is why the SGAs act as antagonists. So they block those receptors, which allows dopamine to be released into the brain and do its receptor function. The term fast on off refers to how quickly it can bind to the receptor and then detach from it, because we don't want it to just sit there and block and just allow extraneous amounts of dopamine to be released, because then we get schizophrenia-like symptoms. Some of the specific medications that we use, some of the older ones, we've got Clozapine, we have Risperidone, Paliperidone, Olanzapine, Quetiapine, and Ziprasidone. And then the newer generation ones, we have Acenapine, Iloperidone, and Lorazepam. And with these medications, I'm going to turn it over to Bree, and she's going to talk about how they're dosed, how they're administered, and talk about some of the nursing implications and patient education.
All right, so taking it from Will, I'll just go over some of the older medications first. So most of these medications are given orally, most commonly, and then some of them are given intramuscularly. Some are given once a day. Maybe if it's an injection, they might get it 1 week, every 2 weeks. It just varies depending on the patient's needs and their dosing. So starting with Clozapine, it's given orally, 75 milligrams to 900 milligrams twice a day. And then Risperidone, it's given orally or intramuscularly. Orally is going to be given 0.5 to 6 milligrams a day, while intramuscular injection is going to be 25 to 50 milligrams. Orally is going to be daily, and then intramuscular injection is going to be every 2 weeks. Paliperidone, the oral route is going to be 3 milligrams to 12 milligrams once a day, while the intramuscular injection is going to be given with at the dose of 39 to 234 milligrams every 4 weeks. Continuing on with some more older medications, we have Olanzapine orally. It's going to be 5 milligrams to 10 milligrams once a day, while the IM injection is going to be 150 milligrams to 300 milligrams every 2 to 4 weeks. Quetiapine orally 200 to 800 milligrams twice a day. And then finally with Ziprasidone, it's going to be orally or intramuscularly. Orally is going to be 40 to 160 milligrams, while the IM shot is going to be 10 to 40 milligrams. Orally, we're going to do that twice a day, and then the shot, the intramuscular shot, is going to be as needed, but we're not going to do that any more than 3 days in a row. So moving on to some of the newer medications, we have Olanzapine. So you have for this one, it's going to be a sublingual tablet or a transdermal patch. The sublingual tablet is going to be 10 to 20 milligrams twice a day, while the patch is going to be 3.8 to 7.6 milligrams every 24 hours. And we change that the same way with our normal patch administrations. Risperidone, we're going to give that orally, 12 milligrams to 24 milligrams twice a day. And then Risperidone is going to be orally 40 to 80 milligrams once a day. So like Will said, the main side effect we're going to see with these medications are going to be like metabolic effects. So sedation, weight gain, diabetes, dyslipidemia, dry mouth, dilated pupils, decreased sweating, blurred vision, urinary retention, constipation, orthostatic hypotension, tachycardia, and then prolonged QT intervals. So overall, just the sedation, metabolic effects, anticholinergic effects, and then those cardiovascular effects. So the main thing we're going to do for patients taking these medications is going to be screening and monitoring for extreme side effects of these medications. So like we're going to be watching for tardive dyskinesia or other other side effects, like even those smaller side effects like weight gain, sedation, things that can be fixed a little bit quicker. But when it comes to watching for those abnormal, uncontrolled movements, we're going to use that AIMS assessment just to make sure we prevent any long-term damage. We also want to educate the patient and their family on what those uncontrolled movements mean. So like I said before, tardive dyskinesia, and then also akathisia dystonia. And that just educating them that those signs and symptoms should be like immediately reported to the healthcare provider. And then one big thing is going to be emphasizing the importance of why they should be taking their medications as prescribed. And then again, swinging back to reporting their signs and symptoms of maybe uncontrollable movements. There are other medications that they can take to lessen those effects and kind of help with TD. So we're going to go to some questions. We have 2 questions. The first is going to be, why are second-generation antipsychotics usually preferred over first generation? And then the second is going to be, what assessment technique would a nurse use to assess for tardive dyskinesia? So I'll give you a second to think about those. All right. So if you said there are less risk for the side effects of first gen, then that's correct. And if you said the AIMS assessment, the AIMS test, then that is also correct. You can find rationales for these answers in your textbook on pages 142 for the first question and page 149 for the second question. Thanks for watching.